Very good afternoon. I know it's very tough. This shift is called the graveyard shift, especially for speakers and as well as the audience. But I must thank Shri Ajay Sani ji for braving it to make the first presentation, and probably he has woken you up with some challenges and issues. I mean, it's nothing to do with our attitude. It's something to do with the body and the physiology of what happens. Once some food goes in, blood rushes to the stomach, less oxygen is available to the brain, automatically we feel like sleeping and all that stuff. It's not our fault. It's the food's fault. And also the organizer's fault for the lovely food that they've offered. What I try to focus on is to look at how do we leverage ICT in the context of rural health, probably with one of the examples for which eINDIA has recognized the work that our people do. I thought I'll just focus on that and probably a little bit in terms of what are the services that HMRI does. First of all, before I start, it might not be a bad idea to tell who I am. One advantage in this podium is I am visible actually. Normally, first I ask, am I audible? Next I ask, am I visible? For vertically challenged people, that's an issue. But in any case, HMRI stands for Health Management Research Institute. This is part of the corporate social responsibility of the Piramal enterprises, who are into multiple businesses. HMRI was born in Hyderabad in public-private partnership with Andhra Pradesh, and I'm very proud to say that the health department of Andhra Pradesh has been at the forefront of pioneering multiple interventions in this country. I'm also fortunate to be sharing the panel with Shri Saniji, who was also the IT secretary and brought a lot of dynamism earlier, about a decade and a half ago. The Triple IT was born when he was there. So many initiatives that you see today were his brainchild, and he had driven them. And I think health department is fortunate to have him. Right now, there's no person who's better to probably talk on IT in the government and integrate all of them and make it happen. I do hope that, quite unlike what normally happens in government, that whenever a person starts doing good work, he is transferred. I do hope that he'll continue with the mission that he has, agenda that he has set here, and we'll be very glad to assist in any form, sir. Starting that is the introduction of HMRI. We are a not-for-profit. The reason why I say not-for-profit so proudly is I'm sure it's a challenge for all governments in the world, whether it's Obama government or whether it's a Manmohan Singh government here or some other government in India, is the healthcare is one industry that lives on the misery of people. All of us. We make our bread when people are sick. But I do hope that from healthcare, we move towards well-being. So like they say in Telugu, Arsu tokkanela, kaalu kadganela. Why put your foot in mud and wash it later? If you can prevent illness, there's nothing better than that. That's the cheapest that a society can do. I'm also concerned that I do not want to take an ideological view, but I do believe that as a community and as a society, there are two services which are public goods. Whatever model we go, privatization, part privatization, PPPs, not-for-profit PPPs, whatever model, net, the overall cost to the society has to be low. It has to be affordable. If you see United States today, they are struggling with trillions of dollars being poured into healthcare and still 20%, 30% of the population not having access to healthcare. They are struggling to change after they got themselves into a rut. I do hope that as a young democracy, that we don't make the mistakes of some of the Western countries which are struggling to take a U-turn today. In that context, I'm very happy to be here, and some of my colleagues from EMRI also are here, that we brought in, Andhra Pradesh pioneered this model of a not-for-profit PPP, which eventually would mean extending the arm of the government in execution, in the last mile execution, by bringing in the capability of the private sector and bringing in some of the technological capability that the private sector probably uses for its own business to improve its own profits and sales. So that is the strength. So sir, there is a great opportunity for institutions like us and the government to work together. That's why we always keep saying we are here to augment, supplement, and support the public health system. The idea, like he rightly said, it has to be an umbrella. Things have to be worked together. Otherwise, there are so many beautiful, independent, silo kind of approaches that have been done, in this country, it's necessary to bring all of them into some platform so that there is some integration. I will not dwell too much upon the challenges in healthcare system. Many of you are erudite people here. You already know them. He talked about the IMR and MMR. I always would like, at the cost of repetition, would like to compare the best IMR in the world and the IMR that is there in India, IMR probably that is there in Andhra Pradesh or some of these states. The best in the world, for every 1,000 live births, only 5 infants die. Whereas in a country like us, it is anywhere between 50 to 70 children who die. That should give you a sense. Where is 5? Where is 50 to 70? Well, 50 is pretty good, excepting probably one state like Kerala, which is about 13 or 12 or something. They're pretty close to some of the best in the world, but definitely not the best yet. Even Sri Lanka is about 13 or so. Similarly with mother mortality, anywhere between 150 to 700 for every 100,000 live births. Internationally, it's about less than 10. Just to give you a sense. More farther you are from a center, more your numbers are like to be like that on the other end of the spectrum. If you're a Dalit, or if you're a tribal, if you're illiterate, if you're poor, you live in a forest or live on a hill, chances are the mother mortality will be 700. Infant mortality will be anywhere between 250 to 400. Now look at 5 and 10, look at 200 and 400. Well, the average tells something. So one of the key things that we find that ICT can do a lot of things in terms of reducing the distances between people, which I'll talk about a little later. I'll also talk about some of the core principles, which already Mr. Sahni did mention, but I'll just give that a little bit of pictorial work. My colleagues have done a lot of work on the graphics part of it. I must share that. There are 3 issues that we always talk about, 3 A's, that is, which become 1 E. Equity is an important thing. Equality may not be possible in our lifetime, never probably. It's a utopian idea. But equity is something that is very important for all of us. Everybody should have equal opportunities is what we say. That comes by providing accessibility, availability, and affordability. The problem is very many times, it's like a stool with 2 legs we work. Either if it's affordable, it's not accessible. If it's accessible, it's not affordable. If it's affordable and accessible, it's not available. So the issue is only when all the 3 legs of the stool are there, can we stand on that and move forward. And therefore, I thought it's important that I bring these 3 issues. Now, this is where I think technology brings in a picture. It creates things accessible, it makes it available, and it makes it affordable. This one slide, I would like you to spend a little time reflecting on it. One of the challenges that I find as a citizen of this country is that while we want to do a lot of good things, the good intents are there, the problem is that we tend to dissipate our energies. Just to give you a sense, Mr. Sahni did talk about sanitation as an important issue. Now, very many times what happens is, sanitation is like immunization. If you provide sanitation for some part of a community, rest of the part still uses open defecation, there's no point, because the fly doesn't care whether rich or poor. The mosquito doesn't care whether rich or poor. It doesn't know your caste, it doesn't know your community, it doesn't know whether you're a PhD or whatever you are. It doesn't do that. So here is where we need to do saturation. So any intervention, so we believe, we always work with our partners and request them, let's saturate. For example, if you have an MMU, one MMU per district, in some states have, it doesn't make sense. It doesn't serve any purpose. It's symbolic, saying that yes, we have given. Instead, if you put all the 20 vans probably in one district, we can see transformation happen in just about a year's time. Fortunately, Andhra Pradesh government was very, very wise, very ahead thinking. So they provided close to 500 vans to cover 20 districts. So that is saturation. So you can actually see impact after a year or 2 years' time. And I'm very happy to believe from whatever first level data that I have, from 53, 54, the infant mortality topped, it tipped down to 48, 49 now in Andhra Pradesh is what 43. That's fantastic. I'm very happy about that. Similarly, the mother mortality also has come down. And we believe that is because the government thought in its wisdom that we must saturate. So that's one principle I'll focus on. And of course, synergy, since we work with multiple partners, multiple stakeholders, it's no single person's job. Like very rightly, Mr. Ajay Sahni said that it's a behavioral change that is needed. If people eat bad food, it ends in illness. Now, how do you change that? If people smoke, people drink, people do something else, unless those things are not changed, nothing would change. If they don't eat high-quality, nutritious food, nothing would change. If a mother doesn't give the breast milk to the child, the immunization of the children is compromised, and so on and so forth. So obviously, everybody has to work together since it's a larger goal that we have at hand. I'll leave it at that. I'll spend a little time on systems and probably leave the rest of them to you. Systems and scale. Systems are extremely, since we are talking on ICT here, that will allow us to reduce costs dramatically. EMRI, HMRI, 108, 104 services put together does not cost more than less than 100 rupees. That's less than $2 per capita per annum. Thanks, because a lot of ICT is used. And that is the wisdom of this particular state to have tried that. Second thing is that along with systems, you have to change the business processes. The problem with technology is, I worked in a technology company. There's a lovely saying that we used to say, if you have a hammer, everything looks like a nail. So for an IT person, everything looks like IT can solve all the problems. IT does not solve the problems. IT, there's also another one, garbage in, garbage out. It's as good as the business process that you have. If you take a meaningless business process and automate it, you will do mistakes faster, that's all. And maybe on a larger scale. So unless we re-engineer the business process, it does not make sense, because that ICT allows us to relook at our processes, integrate them, and probably get efficiencies and optimization. So that's where, that is the power of, all of you know that, I don't have to tell you, but especially in governance and delivering services to the last mile, it's a lot more important to look at the whole delivery chain and see whether business processes can be transformed. That will bring in a lot more value of leveraging ICT. Otherwise, it will be investments, and IT people love to sell one technology after the other. I'm sorry, that was my bread and butter long ago. It is still 10 years ago. We used to talk, without ERP will transform the world. Then we said, now we are saying cloud computing. Day after tomorrow we'll say something else. But that's all right, nothing wrong. Technology has to keep pushing the envelope. But it's very, very important to see whether the technology is contextual. If it's not contextual, it does not make sense. If it does not deliver value to the end customer, it has no value. That's how I look at it. And obviously, with technology, you can scale. It wouldn't have been possible for government of Andhra Pradesh and HMRI to run 475 vans without technology. We knew how many of our vans were actually going there, how many patients came, how many were pregnant women, what are their names, and so on and so forth, what are the diseases. So you could take all the data, you can do slice and dice and analyze all kinds of stuff. That's the power of scale that technology allows you. So I'll leave the rest of them. Like everybody likes, Kotler says 4 Ps, somebody else 5 Cs. So I thought I also should say 6 Cs or something like that, so 6 Ss, etc. But among them, 2 or 3 are very critical. I'll just give an example of how technology is leveraged, both in Andhra Pradesh to begin with as a pioneer and in Maharashtra. In Andhra Pradesh, we set up a citizen call center. A citizen could call if he or she is unwell, or a mother has a child with diarrhea or loose motions at 10:30 in the night. She doesn't know whether the child has to be taken to a hospital, for which she has to take some transport, or she can wait for the night and take the child in the morning when there's transport available. So she can call this call center and ask, these are the symptoms, what should I do? So there's help available who would say, yeah, I think it's very important because you have a baby and you can't be careless. Immediately rush the child to the hospital. Or may say, don't worry about it. Give the child some sugar water or something ORS solution. Let's see, call us after a couple of hours. Or in case it's an emergency, we'll tell you that kind of stuff. So that kind of a possibility is there today, thanks to technology. But the Maharashtra government went one step ahead. It said, look, citizen call center is one, but what I want is I have a large number of last mile health workers. That's the ANMs, ASHA workers, sub-center ANMs. Sometimes the young MBBS doctors who are staffing or manning, because manning is a sexist word, that's why I'm using the word staffing, because there are a lot of women doctors as well, who are staffing these PHCs, and they may not have the repertoire of skills or experience to be able to deal with all the issues that they deal with. Because that is the first port of call for anybody in a rural area. So how do you augment that person's help at the time of, let's say 10 o'clock, the snake bite case comes, or some other bite case comes. What should he do or she do? That's a question. Or an ASHA or an ANM is trying to deliver a baby. She finds the positioning of the baby or the fetus is very different. So what should she do? So these are the questions. So we thought technology can solve the problem. So the Maharashtra government wanted us to do something. So we built a solution, HACC. And since we come from IT, we all love TLAs, 3-letter acronyms. This is a 4-letter acronym. This is a Health Advice Call Center. So this is a 24/7 toll-free health helpline, accessed primarily by healthcare providers in the field. We use close to 700 plus validated algorithms that are current and always updated in both Marathi as well as in English. Of course, we have in Telugu and Assamese and Bengali and all the kind of stuff. There are staff with specialists in paramedics. We also have data about the national health programs. In case the person wants to know, like a pregnant woman probably is eligible for a Janani Suraksha program or something of that kind, we do share that information as well. And of course, we do have summaries of various health facts and all that, laws and acts. Like he rightly said, the MDGs are IMR and MMR, reduce mortality, morbidity, and of course, facilitate or help or add or supplement the health systems. This is a typical call center that you can see that we run out of Pune. The beauty of this thing is that the technology allows us to get a contextual algorithm that a person needs to pick up, depending on the condition that or symptom somebody is asking. So to that extent, we could scale for every one doctor, we could add 10 paramedics, so 1:10. So suddenly the scale became 10 times more, and to that extent the costs have come down in delivering information and advice. We also have a caller-based information pop-up because we have the database of all the ASHA workers and the ANMs with us. The moment somebody calls that number, we know where they're calling from, and also we can address them, say, thank you, Ms. Lakshmi Bai, and so on, and so you can say something like that, right? So that's the, and they'll feel very personalized. And because many a time what happens is the last mile health worker has the least amount of support in terms of delivering service. And these are the ones who are actually what we call in IT, where rubber meets the road. That's where exactly a service need to be delivered. So if this ASHA need to be strengthened at that point of time, she has a problem. She should refer this patient somewhere else, higher up, or she can give some medicine because she's got a kit. Can she give the medicine? She's trained for a short time. It's all possible that everybody needs to be educated from time to time because the healthcare knowledge is changing so dramatically. So constantly somebody has to be available. The beauty is there is a contextual. At 12 o'clock in the night, the woman can call. Or 1 o'clock in the night, because something happens in a village, the first port of call either is the RMP, the informal provider, or the ASHA worker who's there. So how do you strengthen the ASHA worker? So that is something that we're talking about. We also record, of course, we bring these from business practices from all BPO companies. We record all the calls, and then so that we can analyze for quality, attitude, clarity, and so many other things we can do. I'll just move on here. As I talked about it, there are multiple levels of ASHAs, ANMs, and medical officers that we support. I'll just move on. We have various kinds of users. I just did talk about that. And these are the services that are rendered through this specialized call center. That is beyond the citizen helpline. Now, some citizens also call. It's not that they are prohibited from calling, but they have not popularized this among the citizens yet. But people do come to know word of mouth, so they do call us. We believe a call center like this will help even in identifying epidemics much ahead of time. That we have done in Andhra Pradesh. When we got large number of calls about eye watering and eye problems, we figured out conjunctivitis is around. We shared that information immediately with the government of Andhra Pradesh, with the district officials. They sent a team and kind of cordoned it off, kind of closed it within that geographical region so that it doesn't spread. So that's the beauty of IT that we need to look at. And timely referrals, of course, is a very important thing, and all the other things I did talk about that. Pardon me for this picture. We have not yet taken. It's a young call center that we have in Maharashtra. The picture is from Rajasthan, where also we run a citizen health helpline. Basically, what we are saying is that by doing this, two things are happening. The person in the last mile is getting contextual, context-sensitive help, right? Real-time help, that is one. Two is that for every case need not be referred to the PHC. If you look at many of the public health facilities, oftentimes, even a super specialty hospital, 98% of all the cases should have been handled at a PHC level or a CHC level. There's no need to come there. So that way, that load can be reduced on the public health system, apart from increasing the health awareness or health-seeking behavior among people. I'll just give you a couple of cases. Here is a case of a person having an impending heart attack, a 38-year person who called, he was advised appropriately what needs to be done. That obviously there's some kind of a saving there. And here is one case where in a PHC when a woman came and she was being delivered, there are a few issues that I had. The young doctor did not know what to do. He had given some medicines, but he wanted to find out. Our specialist gynecologist did advise what needs to be done, and this woman and the baby was saved to that extent. Otherwise, he had to refer that woman to another 50 kilometers or 30 kilometers in the middle of the night. So that is the beauty that is there. So similarly, there's a bunch of kids who ate some poisonous stuff, and they were brought in there, and the medical officer did not know what to do. And here is where the pediatrician that we have in the call center will advise what needs to be done. So just to give you an example of how ICT can be leveraged, how scale can be done. In Andhra Pradesh, when we worked with the government of AP, we registered close to 1.1 million pregnant women. No other state probably in this country has a record of so many people there, and tracking them for a while and monitoring them for a while. Similarly, close to 1.2 million hypertensives and diabetics are identified and referred. Those records are available. So Andhra Pradesh state that way is fortunate to have all this data where they can do slice and dice, analyze that. We also found patterns, interestingly. We found in some regions of Andhra, hypertension was more. Some regions of Andhra Pradesh, the diabetes was more. The coastal regions, diabetes was more. In the drier parts, the hypertension was more. So these will help in terms of taking some decisions. Apart from that, I told about the VANS FDHS, Sir Ajay Sani also talked about that. We also do a telemedicine center in Araku, 400 kilometers away from Hyderabad, where a doctor is there and the paramedics go on motorcycles or by walk into the hills and do all the services that FDHS does in 140 villages. And those women are brought to a telehealth center there. From there, we have a gynecologist and obstetrician sitting in Hyderabad who does consulting and does the necessary service delivery there. This is what is possible. To cut distances, to cut costs, to cut time. What IT normally says that has been leveraged by corporates. Today, governance, bringing governance closer to people with the help of government. Here are a few examples of what and how one can leverage ICT. Thank you very much for your very patient hearing.